right, and then scroll all the way to the left to make sure that it doesn't open halfway through the presentation.
Sorry, tell me again what you want me to do here.
Present the screen, which I think that's what is presented, and then you opened it up wide, and then if you can toggle arrow to the left to make sure it starts from the beginning.
Yeah,
Just
I believe we're at the beginning. Yeah.
Okay. All right. Thanks for joining us for case reviews for May. Having some technical difficulties with the app on my side, so we're going to present through Dr. Mock, so there'll be a little bit more conversation about forward or next screen. And you should just be able to arrow, Dr. Mock. You don't have to click over the things. So arrow right. Just on your control pad. Perfect.
Okay.
So as always, this information is private. It should not be shared with others. It's protected through the HIPAA Act, and it's what we talk about every month. So you can arrow next. Just the keypad arrows is fine. That's all I ever end up using. So if you're using a Mac, underneath the shift button on the right.
I don't know if I had a different setup from you. I'm sorry, that's not doing it. So
I wonder if you're in present mode. Let me see one more time if I can pull mine up.
I can do it this way. So
Okay.
okay, and then ready to go forward now.
Yeah, and then that arrow, the expand arrow on the bottom right, that should none of that stuff should be shown. So there we go. All right, so first case. Are you sure this is maybe it's the first case? Did it go under first case? Sorry, I wasn't looking at the screen when it went forward.
It did.
Okay, we'll just assume it's the first case. 73-year-old male EMS had found on the toilet with his wife. Next.
Okay. I'm sorry, I just did in full screen. It doesn't seem to be letting me advance.
Okay, whatever it will allow then.
Okay.
So yeah, this is case one. So this is a case of EMS was contacted for seizure. They arrived to find the patient unresponsive, sitting on the toilet. His area was open, but he wasn't protecting. His skin was pink, warm, dry, and there were no signs of active bleeding. Vital signs were obtained shortly upon arrival with a heart rate of 74, a blood pressure of 92/49, a respiratory rate of 18, room air sats of 94%, and a blood glucose of 169. The past medical history that go back. The past medical history that was available to EMS was that he had a history of alcohol abuse. His wife believes that he was drinking even that day. He also is on warfarin for DVT. He has a history of high blood pressure and high cholesterol. The meds that included by the wife were simvastatin, Viagra, and warfarin. She had stated that he's been drinking today. She doesn't know how much to be able to quantify it, and that he was his normal state of health when he went to the restroom. She said that he hadn't come back out, so she went in and checked on him and found him to have seizure-like activity with tonic-clonic activity lasting for about of previous seizures, and he has been known to fall but hasn't fallen in a week, although he wasn't evaluated in the hospital for that fall. So definitely a fall, subacute, hasn't been imaged to see if there's been any issues from that fall. Now having first time seizures. Next. So the call came in at 11 o'clock in the morning. The first set of vital signs I just reported to you guys. At 6 minutes, another set of vital signs were obtained, noted that his Heart rate was still not tachycardic at a 68, but he was more hypotensive sitting on the toilet at 75/44, Respers of 18, and room air sats of 95%. Given his progressive hypotension, the crews elected to pull him off of the toilet instead of lay him flat to help with his blood pressure. They noted that his mental status didn't change, but his blood pressure did improve with another set of vital signs at 11 minutes, showing an improvement of his blood pressure to 122/49. Heart rate remains at 75, Respers of 18, and room air sats of 95. At 14 minutes, they started an IV. At 17 minutes, they obtained another set of vital signs. Stable here with a heart rate of 96, blood pressure 127/54, respiratory rate of 18, and room air sats of 94%. I think that's 19 minutes. It shows that they depart the scene en route to the hospital at 28 minutes. They take another set of vital signs from for the still stable with a heart rate of 93, blood pressure 148/49, respiratory of 16, and room air sats of 96. Next, there should be a little box that comes up. Perfect. So they noted that he was gradually responsive to painful stimuli en route to the hospital. Next, another box should come up. And that when he became more responsive, they noted that he was only moving his right side, prompting EMS to initiate a stroke alert at 31 minutes, and they arrive at the hospital at 34 minutes. Next. Their Pulsara notification is that they code this as red. They notify the hospital that he had some seizure activity that was confirmed by his wife, no history of it. He's an alcoholic. He has been drinking, and there has been no recent reports of a fall. He was on thinners and he was hypotensive, positional, but normalized with lying flat, and that his GCS was initially 3, now a 5. Next. They did enter into the Pulsara BFAST and LAMS, important because whenever we activate these as stroke alerts, they need to be in here. We do not use RACE, so please don't use that as a stroke assessment tool, because we talk about those people that use RACE every month in our stroke committee meetings, because we're not supposed to be using them. Next. So in reviewing this case, I thought that this crew did really a pretty awesome job for a undifferentiated patient that is altered seizing. Could be from a fall, could be um, from a malignancy, or it could be from even his alcohol. So anyways, they did serial vital signs, got an early blood glucose, identified life threats, interventions as he's hypotensive, laid him flat, he was responsive. They documented the response to the treatment. They did serial assessments, noting that the patient was becoming more conscious, but also not moving one part of his body. They notified the hospital of a time-sensitive concern. It is important for us to know about any of these trauma, stroke, STEMIs, and sepsis patients so that we can adequately receive those patients and intervene with time-sensitive care. And they assessed a stroke assessment and entered into Pulsara. They expedited the care to the hospital. Their decision-making with airway management, I thought, was really spot on. Yeah, someone could say that GCS was 3, then a GCS of, I think it was 6, that was absolutely a need for intubation. But you've got a patient who just had a seizure. Is he postictal? Is his SATs normal, which they are? He isn't having any impending problems with his airway with vomiting. So I think that I thought that was probably a more difficult decision not to intubate, given that you could be justified in doing so. And that they notified us of anticoagulation, and they documented his history in the chart appropriately. The only area for improvement, I hesitate to even put that as 12 lead, because if you go back one slide and look at the times for this patient, one more slide, sorry. Back to the treatment. There you go. You can look that they spent 19 minutes on scene. They really didn't spend a lot of time. So if the time allows, a 12 lead. So go back to the QA discussion. All right, and then next. So in the emergency room, he was evaluated immediately due to intubation, or not intubation, due to stroke alert. So they noted that he was in fact hemiparetic on the left side and had neglect. So they upgraded him to a neuro 911. The CT of the head showed possible perfusion problems involving bilateral pons. So he went ahead and got an MRI. Although that MRI showed that this was an overcall, there was no stroke. He was witnessed to have another seizure where he was given Versed. His labs returned notable for an alcohol level that was pretty low at 0.05. He had an anion gap of 25 and a lactate of 14, which might be the etiology for his lab results at that point. And that he had an elevation in his kidney function of 1.33. His ammonia levels are pretty high, which you can see with alcoholics, especially with end stage kind of liver pathology. So that might be contributing to his altered mental status. He again had another seizure. He was given Versed and phenobarbital, and he was intubated that time for status seizures, and he was admitted to the ICU. During the hospital course, his EEG showed severe encephalopathy and sedative effect from the sedation he was getting. He was extubated on hospital day 2. He was started on anti-epileptic medications as well as hypertension meds since his previous regimen wasn't controlling his hypertension, and he was discharged home on hospital day 8. Next. So I thought it might be I think that this case was actually self-reported to be a potential case for case reviews, and I thought it was an excellent case of undifferentiated seizure in an elderly patient with multiple potential risks for the etiology. Ultimately, this patient's seizures were related to alcohol withdrawal, so I thought it might be a good time to talk about alcohol withdrawal with you guys. Most commonly abused substance in the United States is alcohol, particularly after COVID. The use of alcohol has skyrocketed according to the data that I was reviewing, in that the overall lifetime use is 75% from 12 years old to current age. Alcohol works as a CNS depressant, and it stimulates GABA, which is a inhibitory kind of synapse. And as alcohol increases GABA, or the exogenous GABA production, it increases glutamate, which is a excitatory neurotransmitter. So the screen for me is really small, so I assume it's probably really small for you guys too, which is fine. I'm just letting you know that I don't think that you'll be able to see this image here on the right. But my point was that when this is like a normal, oh, there we go. This is a normal transmitter where you've got glutamate released as a excitatory neurotransmitter, and then with chronic alcohol use, you have more GABA produced by the consumption of alcohol, and less of your endogenous GABA is produced because of the fact that a person is consuming a medication or an alcohol that's increasing GABA. As a response for the homeostatic effects of it is that glutamate increases because of the excess of GABA, but when people either reduce their drinking or stop their drinking, that exogenous GABA is no longer being produced, and the body's effect to create their internal mechanisms for GABA decrease, and so they have this response with increased glutamate, which is a stimulant, which leads patients to have the symptoms they typically present with, which could be mild, such as anxiety, nausea, vomiting, abdominal discomfort, headache, or inability to sleep. That can occur as early as hours to after the patient has decreased their alcohol consumption or completely ceased from drinking, and it peaks at 72 hours. It can be pretty severe, where 2% of the patient population will complain of hallucinations, either auditory or visual, and usually subsides within 48 hours. If you've ever talked to a patient who's in alcohol withdrawal, they may be completely oriented, but then you ask them where you are, and they'll tell you something kind of off the wall, like the zoo. So it's not just about orientation questions, but also where are we, kind of like context wise will help you determine if they are truly hallucinating. And then they're no longer using delirium tremens. That's fallen out of favor. And so they're now using wording called withdrawal delirium. And these patients will present with fever, tachycardia, agitation, disorientation, diaphoresis, or hypertension. That's the whole glutamate overstimulation problem. And that they can also have seizures within hours after reducing or cessation of alcohol consumption. I was going to tell you something. Oh, so the withdrawal delirium is a really, really small subset of patients, usually about 1% from the data that I was looking at. And is there anything else? Or I actually corrected myself, 3%. So just a little bit above the hallucinations, but overall a pretty small subset of patients. Some things that are really helpful to ask either in the pre-hospital setting or in the hospital setting when you give us a handoff is, what have your withdrawal symptoms looked like in the past? Have you had a seizure? Have you needed to be intubated? Have you needed to be admitted to the ICU? Those are all really helpful because the patients will likely have be at risk of similar presentations as they have in the past with alcohol withdrawal, and that there's an additive effect where each subsequent withdrawal episode can be a little worse than the previous. So it's good to know what their baseline previous has been. One of the evaluation tools that we use in the hospital is a CWA. It's got some objective findings like and a physical exam, but a lot of it is subjective about how the patient feels. And it's a scale that goes up into the 20s, depending on higher number, the more severe the withdrawal. And then treatment, mild symptoms might be treated with either benzodiazepines or gabapentin tapers that patients go home with, or they'll be hospitalized with benzodiazepines and phenobarbital. It's important to be aware that people that drink heavily tend to not eat or consume normal nutrition, so their electrolytes are likely to be quite abnormal. And then there are some prescriptions that can be written for patients with alcohol dependence in efforts to try to curb their drinking or to completely resolve it. So you may see patients on naltrexone, acamprosate, and disulfiram. You may have even seen this referred to as a trade name antabuse, where these patients will tend to have pretty severe nausea and vomiting, and maybe even flushed when they're drinking. Similar in presentation as Asian glow or alcohol aldehyde dehydrogenase enzyme deficiency. Next. So I think that in searching in our protocols, we don't have anything for withdrawal per se. When you search withdrawal, you go to the protocol for Versed, and so it's an option to give Versed for withdrawal. But I think the closest one we have in our protocols would be seizure management. So if the patient is in status seizures, those are seizures that are continuous or repetitive without a return to normal mental status, you would be inclined to treat them with Versed, ideally 2.5 to 5 milligrams IV or IO, repeated every 5 minutes until the seizure stops and stopped at 20 milligrams. If IV access is not available, you can give IM dosing. 10 milligrams is the recommended dose every 5 minutes until the seizure stops. I assume that it would also be the max dose of 20 milligrams, but Dr. Mock, would you have anything to say about the IM max dose?
I mean, if the patient is seizing, then we would continue to give benzos until the seizure stops. There's not a um, in our transport times, you're not going to get to 30, 40 milligrams of IM midazolam, but I would just continue giving midazolam until the seizure stops. If you're unsure what to do, contact medical control.
Okay. Thank you. And then monitor the patient's respiratory status. As we know, benzodiazepines are going to stop a seizure, but they're also a sedative that might lead to hypoventilation or hypoxia. Check a blood glucose for completeness of your altered mental status seizure differential diagnosis. And if the patient is pregnant, consider consider eclampsia and treat with magnesium. I'm not going to go into the further details under the pediatric side, as that's something that you guys should review if you're not more currently up to date with it. Next. Any questions about the first case of first-time seizure in an elderly male? If there's no questions or comments, please next. All right, moving on to case 2. This is a case of 2 patients. It might just have been coincidence, but we've had 2 similar cases in the last month, so I decided to present both of them. Next. So the first case is of a 69-year-old female. She was complaining of weakness, nausea, shortness of breath, chest pain, and headache. Primary survey is that she was awake, alert. Her airway was open. She was protecting it. Her skin was pale, warm, diaphoretic, and there was no signs of active bleeding. EMS got a set of vital signs pretty early on after patient contact, noted that her heart rate was 47, her blood pressure was 58/41, respiratory rate of 18, and SATs of 100%. She was approximately 68 kilos, and her past medical history included stroke, coronary artery disease, and end-stage renal disease. They were unable to get any history about her meds, but she was coming from a care facility, and the caregiver stated that they had left the room only to return to find the patient slurred with a droop and weakness and complaints of chest pain, and that was about 15 minutes prior to them initiating 911 call. Next. So the call comes in around 11:07. Vital signs at 3 minutes I've already reported. The patient herself was complaining of 7 out of 10 chest pain and 8 out of 10 headache. She reports no loss of consciousness or vomiting, and EMS attempted a BFAST, but stated that the patient was so weak she was unable to perform it. At 11 minutes, an IV was attempted but missed. At 12 minutes, her heart rate was documented as 119. Blood pressure of 154/106, no respiratory rate, room air sats of 100, and a blood glucose of 210. I'm not really certain about what had changed or if that was just a spontaneous change in her blood pressure and her heart rate. At 13 minutes, a 12 lead was obtained, an IV was established, and she was given 100 mLs of IV fluids. Next. So her initial EKG is this. Reading this, it's very wide, it's slow, not 119. And her QRS is 0.188. Her QTC is 0.426. The readout is interventricular rhythm, although there's a lot of potential badness. They interpret it as interventricular rhythm, if I remember correctly. Next. They get another EKG, I think a minute or 2 later, and they have kind of like a stable appearing rhythm in the sense that it's wide, it's slow. Next. And they get another one, which appears stable, but can you go back to? So things I want to point out to you guys is that they did actually 6 12 leads on this patient. So that actually was really helpful and could help this crew, or any crew, pick up the subtleties about this. So the QRS is wide at 0.188. Ideally, we'd get a 12 lead from her previously, but that never usually happens in the pre-hospital setting. But what we can do, especially if time allows and the patient's stability allows, is the serial 12 leads can help us to see if there's anything changing. So we got 188 and 426 for her intervals, forward one. And the QRS is staying the same at 188, but now her QTC is going to 512. Next. And then you have this third 12 lead that you're like, wait, now the QRS is 0.14 and the QTC is 430. I'm not really sure, but the previous one is showing that it's widening in front of you, which should make you think about your differential diagnosis of widening QRS in the acute setting, what things to consider and how to manage it. So next. So at 20 minutes, they got that third 12 lead. At 21 minutes, they initiated transport. They documented that her heart rate was 95. No blood pressures recorded, respers of 16, room air sats of 100%. At 28 minutes, they get another 12 lead. They document her heart rate's tachycardic. And at 30 minutes, they get another 12 lead. They document her heart rate's tachycardic. Next. So you may remember that it was 0.188 and I think it was 526 or 5 something on that second EKG. This EKG shows that you're back to widening complexes next, and that you're widening your QRS even further, and then you go next, that third 12 lead. Now your QRS is even widening further, so it should start to get you worried that this patient might be hyperkalemic or may have taken an overdose on tricyclics. So either way, you're seeing this patient's QTC widening in front of you with hemodynamics that are abnormal. They document multiple tachycardic rates, but I think that was an error because all 12 leads showed that this patient was bradycardic. Next. And they arrive at the hospital at 35 minutes. They document that they did not give aspirin or Zofran because of BFAST symptoms of possible stroke. So for inability to do a swallow evaluation for aspirin, and I don't know for the Zofran explanation, but I assume that's the aspirin explanation. Next.
Did the patient get calcium?
No. Pulsera is that they documented this as a red acuity patient complaining of weakness, nausea, and chest pain found to be an idioventricular rhythm. They document that the vital signs were 53 for a heart rate, a blood pressure 60/40, SpO2 of 99, respers of 16, GCS of 15, and blood glucose 212. Next. So in just documenting or just reviewing the pre-hospital course, early set of vital signs, serial 12 leads, Pulsera notification, I would ideally like to see more blood pressures, especially if we're thinking that we have a really critically ill patient. I believe there were 2 blood pressures recorded. The first 12 lead was greater than 10 minutes. So you've got a patient with chest pain. Ideally, we do less than 10 minutes, especially in this particular case where this patient is hemodynamically unstable. They mentioned that the patient was hypotensive, but I never saw any IV fluids or any escalation of care in regards to the hypotension, as I think the blood pressure they recorded as being normal was actually spurious, not accurate. The vital signs were not consistent with the 12 lead, and more questioning regarding the history of end-stage renal disease, especially consideration of calcium gluconate. The one other thing that they didn't put in here is that please don't document 30 minutes ago, 40 minutes ago, last known normal. Just document the time based off of what time you got there, because when we get that as like pre-hospital, it was 15 minutes ago from when you got there, 15. So just tell the time would be great, just so that there's no error, there's no room for confusion. Next. So in the emergency room, her initial vital signs, heart rate of 35, blood pressure 69/59. They didn't document a respiratory rate, but they documented that her SATs were 96 on room air. They immediately placed her on pads because she appeared to be in peri-arrest. They started her with atropine, and then they placed a second IV and gave her calcium gluconate. The patient had told them that she hasn't been feeling well for the last 2 days, and she was experiencing generalized weakness, and that the ER doc documents the wide complex rhythm is new, but it was documented in this section based off of pre-hospital. So I'm not sure if pre-hospital was aware or if she had looked at the old EKG. Next. Her initial rhythm is this on 12 lead. Remember when you guys were looking at the pre-hospital EKGs, we were starting in the upper limits of 400s. Now her QTC is 584. Next. So because the ER doc was uncertain if this was a heart block or hyperkalemia, she consulted cardiology immediately, and her lab started to return and noted that her potassium was 8.4. She was given multiple rounds of calcium gluconate because she appeared to be decompensating despite shifting. She received Lasix, glucose, insulin, bicarb, albuterol, and then ultimately, because she kept on going, what appeared to be refractory hyperkalemia, a dialysis catheter was placed. The ER doc had brought this case to my attention as she said this was probably one of the sickest patients that she's ever seen, and that her code status was DNR. So in the midst of her potentially arresting from her hyperkalemia, that she had to figure out if she even wanted to be treated for this hyperkalemia, not want to pass away from this potentially reversible cause. Then they were aggressively, I think she said she ended up redosing her 3 or 4 times with all of the meds for shifting. And I just put the code status as DNR as the complicated part of this patient was really sick, and it wasn't talked about code status beforehand, and so she had to kind of backpedal. She was dialyzed on hospital days 1 and 2. She has a history of end-stage renal disease, but did not require dialysis prior. Her previous kidney functions were in the high 2 ranges. Her kidney function on this day was 3.5, if I remember correctly. Her kidney function did improve after undergoing these 2 runs, and she ended up not getting a permanent or semi-permanent catheter, a tunnel catheter, and she was discharged home after discussion with palliative care on hospital day 7. Next shows you the post-treatment EKG, just to kind of give you an idea of how drastically different, which is obviously the hindsight is 2020, but or having her old 12 leads is helpful, but that's what her rhythm should look like when she's not hyperkalemic. Next. Next. And then next. Next case is of a 56-year-old female. EMS was called for cardiac arrest, if I remember correctly. The patient had had a syncope episode, and bystanders were doing CPR. When they arrived, she was responsive to painful stimuli. Her airway was open, but she wasn't protecting it. She was noted to be pale, warm, dry, no signs of active bleeding. Vital signs were obtained shortly after arrival. Heart rate 139, blood pressure 190 over 104, respiratory rate of 14, room air sats of 96%, and blood glucose of 123. Her past medical history is diabetes and hypertension. They were unable to get any history from her, and I guess it was unavailable from the husband either. The husband and her were headed to a business, and while they were walking to the business, she had passed out on the sidewalk, and that the husband had related that she had recently underwent surgery and admission for a toe amputation. Next. The call comes in around 16:11. The first set of vital signs I already presented in the previous slide, and at 2 minutes, they start bagging her. Bystanders had initiated CPR, but when fire arrived, they noted that she had a pulse. They assisted her ventilations because she was agonal, and the husband had reported what I had stated previously with recent surgery. They trialed 3-minute recent surgery and in reports of oxycodone use. At 3 minutes, they gave her 2 milligrams of Narcan. There was no response. At 4 minutes, another set of vital signs are obtained. Heart rate 128, blood pressure not obtained, respiratory rate is 16. At 10 minutes, another set of vital signs. She's persistently hypertensive, 187 over 110. At 11 minutes, another IV, her first IV was established. And at 16 minutes, her first 12 leads obtained. Next. They get this fast rhythm that appears to be wide. The image is not very clear, but the QRS is, I believe, 0.148, and the QTC is 469. Next. I don't know what they coded that first 12 lead as. I believe that was not from the transporting agency, but from what I could gather, they moved towards intubating her because her breathing, although improved, was still shallow and she was still unresponsive. So at 21 minutes, they gave her 160 milligrams of ketamine and 120 milligrams of succinylcholine. They attempted to RSI her. That was unsuccessful. At 24 minutes, they placed an iGel, and I think at somewhere between the 24 and 26 minutes, they attempted to intubate her again. That was unsuccessful. So they placed another iGel and left it at that. At 27 minutes, they initiated transport and a second EKG next. If you remember previously, the QRS was 0.46, now it's 0.25, and the QTC is similar to the previous. So you're seeing widening QRS from serial EKGs, and they interpreted this as AFib with RVR in the chart. Next. At 28 minutes, they do another set of vital signs. Heart rate's 122, no blood pressure recorded, ventilated at 12, end tidal 40, and at 33 minutes, she goes into cardiac arrest. They document as initial rhythms PEA, they initiate CPR, they arrive to the hospital at 37 minutes with ongoing CPR. Next. The pulsar notification is that she's red. The chief complaint is she's unresponsive and intubated, and that her left pupil is fixed and dilated. Her vital signs were recorded or reported the same, similar to her ESO documentation. So tachycardic, hypertensive. They write a little tachypnic with a GCS of 3 and a normal glucose. Next. So in reviewing this case, I thought that identification early on that she had a pulse, that CPR didn't need to be continued, but they could support her ventilations, considering potential opioid overdose, early vital signs, including a blood glucose, and history of what had previously preceded, and a 12 lead for a syncope, areas for improvement, EKG interpretation, an earlier 12 lead, the first one was 16 minutes, lack of vital signs repeated, especially prior to intubation, so not knowing if this patient was actually stable prior to intubation, induction agent chosen of succinylcholine, and decision-making for this airway securement, especially in this particular case. So you've got a very abnormal EKG that warrants further consideration. And although this patient doesn't have a protected airway, she's not hypoxic. So I think that there would be some time that could go towards managing the EKG concerns, especially because the induction agent could have further contributed to her decompensating. Next. So in the emergency room, CPR was ongoing when they arrived. They gave her 1 milligram of epi, and her next pulse check, she had ROSC. They noted that her ROSC vital signs, heart rate of 141, blood pressure of 148 over 123, respers of 24, and her initial SpO2, despite an IGL, was 53%. She was intubated without any meds, but she developed VFib with the attempt. They ended up defibrillating her 3 times. They gave her 300 milligrams of amiodarone and 1 milligram of epi. Her labs returned with hyperkalemia, potassium of 7.2, and a pH of 6.87. They aggressively treated her for hyperkalemia with an ART line placed because I think she developed hypotension. They had imaged her head, her chest, her abdomen, pelvis, all of which were negative. And further information from her last visit was 11 days ago. She was admitted for osteomyelitis secondary to her diabetes, where she had an amputation and she was on a 2-week course of Bactrim. During the hospital, she continued to be hyperkalemic, so she underwent continuous renal replacement therapy. She was extubated on hospital day 3 with severe agitation. They believe she developed hyperkalemia from her Bactrim that led to her cardiac arrest, her VFib arrest, and her respiratory arrest. And she was discharged home, which appears to be neurologically intact on hospital day number 7. Next. So I know over the years I've talked to us about hyperkalemia, and I think that these are 2 examples that probably need to review it again. There's 3 causes that can lead to hyperkalemia, and that can be increased potassium intake. That shouldn't be an issue if you are a normal adult with normal kidney function, but if you're not a normal adult and you have kidney disease, it might be worth asking, what have you been consuming things that are high in potassium? Things that are high in potassium are red meats, spinach, like vegetables could include spinach, beets, potatoes, cantaloupe, carrots, bananas, broccoli, or even dried items such as like dried fruit, nuts, avocados, seaweed, all increase the potassium intake that people take in, and if your kidneys can't excrete it, that ends up being an issue. I think we spent a lot of time talking about crush injury, burn injury, kidney disease, but this might be another great example to warrant when we don't have clues that either from the past medical history or the presenting history that should make us concerned. So intracellular causes for potassium shifts from the cell to the serum or systemic system. So whenever there's cellular injuries such as excessive exercise or crush injuries leading to rhabdo, impairing kidney function, which we'd spent a lot of time talking about, but I don't think we talk about these other ones as much. So metabolic acidosis, that leads to decreased circulation and perfusion. That can lead to potassium shifting to try to alleviate the acidosis. Sepsis and dehydration can lead to decreased blood pressures, which lead to decreased tissue perfusion, which leads to metabolic acidosis. And the body's way to compensate is to take potassium out of the cells into the serum or the systemic system. Diabetic ketoacidosis, same issues. You've got metabolic acidosis, dehydration, potassium is shifting out of the cell. Medications, succinylcholine being one major offender. Tumor lysis syndrome, a patient who has a known hematologic cancer that started chemo, and all of those cancer cells have started to die or lyse. So they excrete all the contents within the cells, which increases the chances for elevated potassium levels. And so, can you go next? All right, so defined any potassium above 5.5, mild is 5.5 to 6, moderate is 6.1 to 7, and severe is greater than 7. So looking at this complex, normal complex, you're looking at on the top one as we start to higher levels of potassium from top to bottom. So you start to see a peaked T wave. You can start to see peak T waves, widening QRSs, widening QRS, as well as the continued widened peaked T wave, and then further progression to a pattern that looks like sine wave that eventually deteriorates to asystole. When a patient has hyperkalemia, they have abnormal heart and skeletal muscle function, so they might be having lots of cardiac issues, hypotension, problems moving their body or motor exam. And then risk factors are going to be similar to the causes. So known kidney disease, some medications are a component, metabolic acidosis for whatever the cause, potentially intake, that dietary indiscretions in patients that have renal disease, and some meds. Next. So I think that we talked about this pretty well in the cases, but there's another opportunity when you don't have an old 12 lead with the importance of serial EKGs. Next. So this is the first case. You've got a QRS of 188 and a QTC of 426. Next. And you see this QRS widening after serial EKGs. If you haven't already started to treat for hyperkalemia by even giving just calcium gluconate, it would be worthwhile to treat for hyperkalemia if you're seeing widening QRS or widening QTC or both amongst your visit with the patient. Next.
If I could just jump in, I would just say, I mean, this EKG is really classic. Like the next one's more confusing, but this slow and wide EKG, there are very few things, 90%, 90+% of the time, this is going to be hyperkalemia when you're slow and wide. And the downside of the calcium gluconate, if you suspect it at all, is really low.
And before you go next, if you're even thinking that this is VTAC, slow VTAC, that should be like, even the idea of slow VTAC should be like, is this hyperkalemia? Because VTAC should not be slow. As this particular case, they were, even the ER doctor's differential included third degree heart block. I maybe if you see marching out AV dissociation, but I don't really see that, and especially as you're seeing serial EKGs widening in front of you. But yeah, exactly. Calcium gluconate rarely is going to cause any particular issues that are going to be further life-threatening. It's a placeholder. It's the first med you should give for hyperkalemia because it prevents them from destabilizing into cardiac arrest. And it doesn't shift anything, but it keeps the cell membranes stable. And I mean, if you're making your best efforts, this particular patient had a history of chronic kidney disease, not on dialysis, but that should also warrant concern. But like I mentioned, all the other potential reasons for a patient to go into hyperkalemia that aren't from underlying known kidney disease. Go next. This one, you've got a patient who's syncopized, who's got this wide QRS that almost looks BTAC-ish. That's fast, but if you get serial EKGs as this crew did, you've got a QRS of 4.8 and a QTC of 4.6. Next shows that the QRS goes to next, yeah, it'll just drop down. Shows that the QRS is widening at 0.25 at this point, and the QTC is staying the same. This is another case of if you aren't thinking about hyperkalemia shifting, at least try to avoid giving any meds that we know are going to further raise the potassium like succinylcholine. Next. So just our protocols, hyperkalemia, recognizing the signs and symptoms. We talk about dialysis patients all the time. There are other reasons to consider hyperkalemia. Anyone who's predisposed with muscular dystrophy, paraplegia, quadriplegia, crush injuries. But please remember that anything that can lead to metabolic acidosis can also cause potassium to be elevated. You want to get a 12 lead. You want to check their signs and symptoms because it affects their cardiac and muscles the most. They might have these symptoms or this presentation. You're going to give them IV fluids. You're going to give them calcium as the first option, and then the rest of the meds allow you to shift them. So 1 milliequivalent per kilogram of sodium bicarb. Usually it's 50 milliequivalents based off the box. And North Country can repeat the calcium. I feel like I messed this one up last time, but my understanding is that North Country is the only crew that can repeat the calcium or bicarb after 30 minutes if there's if there's signs of worsening hyperkalemia. Of course, you can always call online medical control if you're not North Country. And then albuterol, 5 milligrams continuous for a max of 20 milligrams, and followed dysrhythmias. And is that correct? Only North Country can repeat?
That's that will be clarified in the next protocol update. That's time dependent, not agency dependent.
Okay, cool. That's great. And then next. Any questions about hyperkalemia, these cases? If you were on the call that you wanted to present your thought process or whatnot? Next. 69-year-old male next that EMS gets called for unresponsive in bed. They find this patient unresponsive, painful stimuli. His airway was open, but he wasn't protecting it. He had no signs of active bleeding. His skin was normal for what they document, and vital signs were obtained immediately upon arrival with a blood pressure of 202/168, respirators of 14, and a blood glucose of 106. His past medical history included AFib, coronary artery disease, and hypertension. They didn't document any meds in the ESO section of meds, but they do present to the hospital that he was on anticoagulation. History is that the wife had reported he wasn't feeling that well because he slept poorly the night before, so he wanted to take a nap at around 9 a.m. He wasn't really complaining about anything, didn't elaborate what he meant when he said he wasn't sleeping well, in that the wife went to wake him up, but she couldn't wake him up. Next. So they get the call at 15:26. At 1 minute, they repeat vital signs, noting that his heart rate's 114, respirators of 15, and SATs of 96% with an end tidal of 19. At 2 minutes, they get a 12 lead. Next. And there's a little bit of artifact in here, but it looks narrow, tachycardic with some evidence of ectopy, overall normal axis, and the intervals appear to be normal, and I don't see any ST elevation. Next. They get another set of vital signs at 5 minutes. He's tachycardic still at 100. He's still hypertensive at 202 over 168, respirators at 18, and tidal of 20. At 7 minutes, they establish an IV. At 10 minutes, they establish a second IV. They give him 400 cc's of IV fluids, and they pre-oxygenate him with 12 liters nasal cannula. At 12 minutes, they get another set of vital signs, still tachycardic, still hypertensive. SATs are still normal at 99, and they're bagging him. And at 14 minutes, they give him, I'm not quite certain, but they gave him 5 milligrams of IV for SED, and they document, I write IV because they had documented IM, but stated that they couldn't enter IV. So just as a reminder for me. And then he got 150 milligrams of succinylcholine. They RSI'd him at 15 minutes, first pass at 7.5 ET tube. And at 18 minutes, they gave him post-intubation sedation, pain first with 50 micrograms of fentanyl. 24 minutes, they give him 5 of IV Versed for his post-intubation package. At 25 minutes, they initiate transport. He's still tachycardic at 128, hypertensive 232 over 139, and Title 47. They give him another dose of fentanyl, and they initiate him in their documentation as a stroke alert. They say it that way because the Pulsera says a little different. And at 29 minutes, they give him 100 milligrams of ketamine for his post-intubation sedation. It looks like maybe they didn't have ketamine initially and another agency brought it for why it wasn't used for induction. At 33 minutes, vital signs are essentially unchanged. And at 34 minutes, they give him another dose of fentanyl and they arrive at the hospital at 35 minutes. Next. Pulsera, they don't have any activation for any particular issue. The chief complaint is RSI and hypertension. They don't have any vital signs recorded. Next. So the good is that early vital signs, 12 lead within 10 minutes of patient contact. The stroke alert, although Pulsera conflicts that that was actually relayed, but I think that definitely a good consideration that it was on the cruise team or cruise mind. The exam, they examined his tongue. They noted there was some trauma to his tongue and that his pupils were normal and that they felt like he had some decortic posturing, serial vital signs, airway protection, and areas for improvement. I'm not quite sure why Versed was used over ketamine, as our protocol says ketamine or etomidate unless neither are available, and then to use Versed. Next. So in the emergency room, EMS was notified that the patient does take Eliquis from EMS and that the family member tried to wake him at noon, although the call came in at around 3 o'clock. His initial NIHSS, which was pretty high at 26, they talking to the ER doc, he was notified of this patient as an undifferentiated altered mental status intubated, so it wasn't in his recollection as being a possible stroke. At 25 minutes, he reviewed the CT of the head. I don't think that I had a chance to magnify that, but he noted this hyperdense lesion at the basilar area, and he thought that this part of the brain did not really light up and thought it was a little bit abnormal. So he called the neurologist and told him that he was concerned that this patient might have a stroke, and he called the radiologist to say what's going on with the midbrain. And at 35 minutes, he decided to call it a Neuro 911, so he upgraded it. That was before any formal reads came back yet. At 44 minutes, the CT scan showed a basilar artery occlusion that extended to the left posterior circulation. He contacted neurology again to update them regarding this. This patient was not a candidate for TNK because it was greater than 4 hours since he had gone to take his nap, but he was a candidate for a thrombectomy. He went to the cath lab for a thrombectomy. They removed this lesion out of his basilar artery and PCA. At hospital day 1, they got an MRI of his brain. He had multiple areas of acute infarct as well as hemorrhagic transformation to the thalamus. At hospital day 2, the family was contacted, and they, Lawrence, would you mind? I'm going to silence you. Hospital day 2, the family had a meeting. He had a poor prognosis, a poor neurological exam, and they recommended palliative care. At hospital day 8, he had a repeat MRI that showed no further hemorrhagic transformation, but continued edema and now a right-sided stroke. So given this information, they transitioned to comfort care and they compassionately extubated him. And on hospital day 10, he had passed away. I'm not sure if you're able to pull up that video at all. You can, that's fine. I sent you a video, but it's just a video showing that the basilar artery goes away as you run through the video, but it may be.
You sent that via email?
I did, but it's not a huge thing. I just
okay.
If you can find it, but you can go to the next slide and I can talk about it.
Okay. Yeah, I'm just downloading.
So this is a case of a basilar artery stroke, which can be very difficult to find, and they're pretty rare. Some sources say that they occur 1% of the time, and some sources say they occur up to 5% of the time, and oftentimes found post-mortem. So the basilar artery is this right here, and it supplies the cerebellum, the brainstem, the occipital and medial temporal lobes, as well as the thalamus. And it supplies the bifurcating vessels to the pons and midbrain, so pretty important. And it's supplied from the vertebral arteries that confluence to create the basilar artery. The basilar artery strokes can occur from vascular dissection, thromboembolic disease, and atherosclerotic disease. The number one, oh, did you get it up?
I have the video when you're ready. But...
yeah, yeah, go ahead and pull it up and I'll just talk about it real quick.
Okay, take me just a second to switch which screen.
Yeah. If you want to run it and then kind of what you guys can't see, there's this, I wish I could, so there's this white circular dot just, if you're looking inferior to the calvarium, can you circle over that real quick for them? There. So that's the basilar artery, and that is the contrast in the blood vessels. So as we play it, you'll see it disappear.
Yeah, right there. So then it goes away.
So it's just representation of this really important vascular structure being occluded and having some pretty profound sequela from this type of stroke. And then we'll go back to the other screen when you get a chance. Great. And so the number one risk factor for this, up to 70%, is hypertension. Other risk factors include diabetes, coronary artery disease, stuff that affects the effectiveness of the luminal flow, so atherosclerotic disease, smoking, and peripheral vascular disease. Male have a 2-to-1 propensity for basilar artery strokes, and thromboembolic disease tends to hit people in their 60s and 70s, as it did for this particular patient. The presentation has 3 potentials, but overall these can be very difficult, either that they're kind of mixed and that it's difficult because they're kind of vague symptoms, or that their patient's unconscious. But one presentation can be rapid onset with decreased level of consciousness and motor and oral lingual complaints. Another presentation might be stuttering symptoms over days, and then they have this rapid decreased level of consciousness and motor and bulbar symptoms. Or another presentation is that they have complaints of like neurological complaints like headache, vision loss, neck pain, diplopia, dizziness. They might have some tonic-clonic activity, numbness, or even hemiparesis and ataxia. The treatment is recanalization either by systemic TNK or catheter-associated TNK or thrombectomy. And the prognosis, if unidentified, untreated, or let's say untreated, is 85% mortality. Treated, it's still 40%, as this patient did not have a good outcome, although he survived, that his family withdrew care. Next. So I think the protocol that best displays this patient's unresponsiveness would be the altered mental status one, checking for electrolyte abnormalities as in hyper or hypoglycemia, and if there's a consideration for a CNS depressant in the form of opioid in treatment with Narcan. Next. Any questions or concerns? Next. Oh, is this? Oh, I might have the stroke step up next. Yeah. So if you're concerned for stroke, identifying or assessing and documenting BFAST or reasons why you couldn't do a BFAST, as BFAST is the only stroke assessment score that we recognize or support. And then if BFAST is positive, identifying and scoring a LAM score. If the patient is suspected to be suspected to be a bleed, then we're going to be aiming the end tidal for rates of 35, and then titrating oxygen so that they don't develop any hypoxia, as that is known to be a bad outcome portender for hypoxia with this condition. And then reassure patient if conscious, may understand and hear all conversations being said. Basilar artery occlusions can lead to a condition called locked-in syndrome, so they may not be able to communicate other than by their eyes, but they can hear and see fine. And then any patient with a positive BFAST less than 24 hours meets the criteria, or any patient with profound paralysis, aphasia, or comatose. Critical is if they're profound paralysis, aphasia, or comatose, and they should be going to the stroke facility with a few exceptions. Next, I think, is the exceptions. Any patient with a LAMS of 4 or 5 should come to Peace Health. And if they're not available, going to a neurointerventional facility. If any patient over the age of 80, symptoms that have been more than 3 hours, so outside potential thrombolytics, but less than 24 hours. If you think there's a bleed, and they can go to the closest stroke facility if their symptoms are less than 3 hours, as they can get TNK there. Or if they're suspected to be a TIA. One of the things that the stroke coordinators have asked us to do is, if you are able to put it in Pulsera, the patient's medical decision maker, so that if they're trying to get them consented for TNK or even for thrombectomy, then we don't delay in trying to find a contact information for the person that would make those decisions. So they would really appreciate if you put it in Pulsera, the patient's POA and their number. Next. Next. All right, and in case 4, I usually ask you if you have any questions, but I have to work in 55 minutes. So we're going to go through this now. Case 4. Case of a motor vehicle crash, single vehicle hitting a concrete underpass and being unsteady on an angle. Next. So EMS gets called for a motor vehicle crash. The patient is altered, unable to provide a reliable history. They find that he's alert, but not normal. His airway is open, protecting. He was known to be pale, clammy, and diaphoretic with some bleeding from the extremity, but no obvious hemorrhage. Vital signs were documented. And I only have the transporting agencies chart, as I wasn't able to find the fire chart. But they get vital signs at 1 minute, heart rate of 140, blood pressure not able to be obtained, respiratory rate not recorded, and estimated weight of 63 kilos, unknown past medical history or meds, and that the history they have is that this was an older pickup truck that did have airbags that impacted an underpass wall. There was no additional information. There were no witnesses. Next. It occurred at 1:15 in the morning, and they noted significant front intrusion. They gave us in the pre-hospital handoff that the airbags went off, but it wasn't in the ESO chart, that the patient was lying across the center console and that they required 20 minutes of extrication to get him out and to shore up the vehicle because it was precariously perched. The patient was combative and screaming about his leg and needing help, and then became combative towards EMS, kind of swiping or hitting at them. They documented that they made multiple attempts for a manual or automated blood pressure cuff, but they always failed. Because this was the transporting agency, they had a 4-minute scene time, but prior to transporting the patient, they established an IV and gave him 400 mLs of IV fluids. At 5 minutes, they documented tachycardia at 137. At 8 minutes, they documented tachycardia at 127, end tidal CO2 of 9. They documented that they manually obtained a respiratory rate in the narrative and said that the respiratory rate was 22. They stated that they used an end tidal CO2 to monitor for shock, and they gave him at 9 minutes 100 micrograms of fentanyl. At 11 minutes, they reobtained vital signs, heart rate 124. They documented a respiratory rate of 6 and end tidal of 9. At 12 minutes, they documented end tidal of 9. And at 14 minutes, they arrive at the hospital and they state, when arriving at destination, ketamine used for pain and to mildly sedate patient. So they gave 25 milligrams of ketamine. And they also document in their narrative that the patient became unconscious while being wheeled to registration in the hospital, but his respiratory rate was 18. And in their charting, they documented that the patient had facial, chest, abdominal, and lower leg and thigh injuries from his motor vehicle crash. Next. They activate this patient as a yellow. They put in Pulsera that was high speed MVA into a cement barricade, no loss of consciousness, right leg deformity, altered mental status, broken collarbone, combative, not staying still. They state that his heart rate is 134, there's no blood pressure, respiratory rate of 22, and then they document GCS of 15, which I think would probably be not accurate based off of the patient's presentation and their documentation in the chart. Next. So QA discussion, scene time, because it was only 4 minutes for the transporting agency. I don't know how long it was overall, but they did document that there was barriers to get him off scene because it took 20 minutes to extricate him. They got IV access. Remember, we were using permissive hypotension, but with his end tidal CO2 of 9, that probably can assume he's in shock, and his behavior is probably more related to hypoperfusion than from normal baseline behavior. They attempt and document that they tried to get up vital signs. They documented delays in care. They did an exam and ultimately found all of the findings that you could find for exterior exam. And they used alternate measures for monitoring deterioration in this patient. The acuity on Pulsera probably should have been a red. Well, it should be a red. Communication on Pulsera was a little not congruent with the patient's history, as he was altered, not a GCS of 15. And I think that the intent of ketamine use is not for sedation, even though 25 milligrams would not sedate this patient. But if you're worried about needing sedation, you should be moving towards our sedation protocol instead of looking at ketamine as a sedative. And then the completeness of vital signs. Next.
There just was
Yes.
there any comment like whether the patient had a radial pulse or
No.
any?
No, but
So, I
they
mean,
documented a heart rate the whole time, but they never documented the quality of the heart rate.
Yeah, just I mean, clearly the patient's in shock. It helps if you can document if there's a radial pulse. I mean, in TCCC, I mean, titration, even titration of like the blood products is just based on mental status. So it means the patient is clearly in shock and altered.
Yeah, absolutely. And that's a good point. So I took care of this patient in the emergency room, and the nurse had brought over the Pulsera and said, should this be a trauma consult or a modified? And I'm like, I don't know, the altered mental status, we have to probably assume it's a head injury, so we'll call it a modified. But because the vital signs, there was no blood pressure, but everything else looked okay besides the tachycardia. Anyways, the patient arrives with a GCS of 6. When I went to assess his lungs, I didn't hear anything because I looked at him and I'm like, I think he's not breathing. And he had like this far off gaze. He wasn't focusing on anything in the room. He wasn't responsive to painful stimuli. But his eyes were open. And when I asked about it, they had said, the EMS crew had said, well, we just gave him ketamine. I'm like, oh, well, maybe this is like ketamine induced kind of delirium, alteredness. He was known to be immobilized. And when they gave me the Hanoff report, they were like, well, we gave him 25 milligrams of ketamine. I'm like, that's not why he's altered. Like, that's such a small amount that it wouldn't make him be like our back in the day dosing for ketamine. So at that point, my biggest concern, besides the fact that I could see the seatbelt sign on his abdomen while he was immobilized, this is not this patient. Actually, his seatbelt sign was worse and it was only on the left side. Was that he needed his airway protected and he was really sick. So his initial vital signs, heart rate of 116, a blood pressure of 152 over 111 with a narrow pulse pressure concerning for shock. His respiratory rate is 9 and his SpO2 was 98%. We did a fast ultrasound on him, or I did, and he had a positive Morrison sign, so concern for intra-abdominal free fluid in this setting, concern for bleeding. He was upgraded to a full trauma based off of his mechanism, his positive fast, and his need for airway management. He was intubated once his pressures were supported further because he was hypotensive. So he ended up getting blood and TXA while trying to normalize his pressures prior to induction. He ended up getting a massive transfusion protocol, and they treated him empirically with hypertonic saline due to concern for a head injury. His imaging findings was that he had large volume hemiperitoneum. He had an aortic injury just above the iliac artery with transection but contained bleeding. He had transected multiple bowel based off of the CT results, and he had an unstable lumbar fracture. He also had a femur fracture, comminuted, a calcaneal open fracture on the left side, and a left humerus fracture. He didn't have great pulses in his right leg, which we initially thought was from his femur fracture, but he actually was because of his aortic injury. The reconstituted flow was pretty abysmal, so that's why he didn't have any pulses. His labs showed hemoglobin of 9.9. He was pretty acidotic when he first arrived at 6.73. His lactate was 17, and he had a bicarb level of 9, suggestive of pretty severe metabolic acidosis from underperfusion. And he went to the operating room immediately where he had multiple small bowel perforations. He also transected his mesenteric artery with ischemia to that bowel, so he had to have that resected. They also repaired his aortic injury with a bypass graft, and he went back to the OR on the hospital day 1 because he was having bleeding. They did a splenectomy. They went on that same case, they did external fixation of his right lower extremity, fixating his femur and calcaneus with a washout. He went back again because of ongoing bleeding, and they sutured his pancreatic bleeding. He's currently admitted. They noted they want to take him to the OR more for his fractures, but he's hyperthermic and his white count's elevated, so they're not sure if he's infected at this point, but he's stable, he's extubated, and doing okay for the circumstances. Next. So I spoke with the crews about the importance of a seatbelt sign, and I agree they had a sick patient, they had multiple injuries, but it's really important to relay a seatbelt sign because, and especially in your narrative on the pulsaric, because you're trying to convey what might be your potential injuries to this patient, your worst potential injuries. So in this particular article, it talked about that, obviously we wear seatbelts to try to prevent injury, but under certain circumstances, such as high velocity motor vehicle crashes, they can actually be the cause of the injury. And that is you're aware that seatbelt pattern bruising can occur wherever the seatbelt is. So if it's just a lap belt or if it's a diagonal over the shoulder, you're looking over the neck, the chest, as well as the abdomen. If the seatbelt is not properly placed, it will be above the hips, and so more injury potential to the abdomen. It can lead to vascular injuries of the carotids. It can also lead to solid or hollow organ injuries and or fractures. In this particular case, the radiologist had called and said that he had such a blunt injury to his abdomen that it was concerning that it would almost was such enough force that it could have transected him, like that he had an aortic injury, a lumbar injury, and multiple bowel perforations. But so just it speaks to the high velocity of this crash this patient was in. And seatbelt signs are correlated with increased risk to visceral injuries. And if you're a front seat passenger, you're 2 times the risk of having abdominal injury than your backseat passenger with a seatbelt sign. In this particular study, they just looked at 117 injured motor vehicle crash patients, and 12% of them had seatbelt signs. Of those 12% with seatbelt signs, 64% had abdominal injuries. They looked at patients that didn't have the same patients that didn't have the seatbelt sign, and they tend to have fewer abdominal injuries as suspected. But my point is that we talked about a case a couple months ago about a pediatric with a seatbelt sign that had some particularly significant bowel injury. So another example of like making sure you convey a seatbelt sign in your Pulsera, because that can really, like this can really help us in preparing for the patient. Next. So just reviewing our protocols on red acuity. I was looking at this particular patient. This patient had a femur fracture and a humerus fracture. So it could have been charted as a red because of two proximal suspected fracture of 2 or more proximal long bones. But it definitely, so I don't believe that it was conveyed that they had 2 extremity fractures, just the femur fracture. So I think that was one of the reasons why it wasn't coded as a full trauma, just as a modified trauma. And then as a reminder, our moderate risk or our yellow criteria, this patient had significant intrusion based off of what EMS had reported, which we don't expect you to say how many inches. You can just say significant intrusion, and we can interpret that as like the highest potential for modified. Yeah, I think that's the major ones. Next.
If I could just jump,
Yeah,
I would say,
absolutely.
I mean, the patient is shocking. I would bet my next month's paycheck that his heart rate is greater than his systolic blood pressure, even though there's no systolic blood pressure documented. There's no documentation of whether there's a radial pulse or not. But certainly if you don't have a radial pulse, that's another sign he's shocky. But he's altered heart rate greater than systolic blood pressure. I'm pretty confident his systolic blood pressure would be less than 90. So it multiple criteria that meets criteria for red trauma.
Oh, absolutely. Yeah. I mean, the vital signs are not being makes it a little bit harder, but yeah, I absolutely agree. Like this is a red patient, and it sounds like even for this crew that the patient became unresponsive when they arrived. That's something that it's worth saying. This patient had an acute change in mental status, so that we can shift gears, because the response of, oh, he got ketamine, makes you kind of downplay, even the provider downplay the potential severity, and then realizing it wasn't the ketamine at all that caused him to be altered. Luckily, in this patient's case, he didn't have any head injuries. He just was really sick from his hemorrhagic shock and his potential for contamination from his bowel perforations.
Yeah, no, I'd agree, but I think he meets. They did a great job keeping scene time short, but he meets.
Yeah.
I mean, he also it sounds like he was really unable to follow commands, combative. So, he meets the alert criteria even before that change in mental status.
Oh, absolutely. Absolutely. 100%. I'm just more conveying when there's a change, don't be afraid to mention that before you even give like the rest of your, like, like this patient has decompensated or deteriorated even now. So like, I'm more of like conveying if you had an acute change and it hasn't been conveyed in your Pulsera, don't be afraid to mention that before the formal handoff.
Agreed.
Yeah. Next. So this is just a summary. Next. Next. All right. So patients that drink alcohol, it's a lot of our society. So be aware of it. Not everybody is going to have dependence or withdrawal symptoms, but it can be even a few hours to couple days after the decrease or cessation of alcohol, and they can be mild symptoms to severe symptoms, including alcohol withdrawal, delirium, and recognizing that previous withdrawal symptom severity is important because it can be a portender of what this patient is going to present like this time, and expect that it could be even worse. Hyperkalemia. It's not just your renal patients. It's not just your crush patients. It's not just your peak T waves. Anybody that has widening QRS and potentially QTC, calcium is relatively benign unless they're hypercalcemic, and that's a rare subset of patients. But give calcium to stabilize the cardiac membranes. If you're seeing serial EKGs showing worsening interval delay, then I would strongly encourage consideration for hyperkalemic management. Basilar artery, and then remember that it doesn't have to be renal and crush injuries. These are anybody that has severe metabolic acidosis, either from DKA or from sepsis or from dehydration. And then going up to the upper right, basilar artery occlusions. This is a vessel that supplies a large percentage of the midbrain, and that these patients can have decreased level of consciousness, rapid, severe. They can also have other complaints such as kind of non-specific disease neuro complaints that it's really important to have it on your radar, know it's rare, and to identify, if possible, to hospital your concerns. And then lastly, motor vehicle crashes that involve seatbelts. It's if you see a seatbelt sign, the chances for intra-abdominal or intrathoracic injuries are higher. It's worth recognizing and identifying it, as well as conveying it on Pulsera or in your handoff report, ideally in Pulsera, as we try to determine the appropriateness for reception of your arrival. Yeah, I think that's the major stuff. Anything else you'd ask, Dr. Moth?
No, oh, I agree. Thank you. Great job.
Yeah, thank you. I'm sorry that you guys don't have a refusal. I couldn't find a refusal off of the report. So next month you'll have a refusal.
No,
Next.
thank you.
Yeah, sorry. And then just resources that I used in next. As always, email me if you have any questions or concerns, or you have any great cases that you'd like to present in case reviews, or for me to present on your behalf. Thanks.
Thank you very much. Appreciate it.
Thank
Belated
you
Happy
so
Memorial
much.
Day to the veterans.
Yes, happy Memorial Day, and thank you for running the PowerPoint.
Take care.